All right, guys.
All right, so I guess this is our audience today. Okay. So thank you for joining me. For those of you who don't know me, I'm Sue Fay. I'm one of the PGY3s in sports medicine this year. So the topic of my discussion today is exercise-associated hyponatremia in endurance sports. The reason I chose this topic was, one, I wanted to freshen up on the topic, and two, I want to use this as an opportunity to generate some discussion around the diagnosis and management of this particular very relevant condition. So the definition of exercise-associated hyponatremia, abbreviated as EAH, is any hyponatremia occurring during or up to 24 hours after physical activity. So as we all know, hyponatremia is defined as serum, plasma, or blood sodium concentration that is less than 135 millimoles per liter, and this is typically the lower reference range set by most labs. So EAH is classified clinically into asymptomatic and symptomatic cases. The asymptomatic ones are typically detected in research settings, as you would expect. For the symptomatic ones, you can have mild cases with non-specific symptoms, as well as severe ones with essentially neurological sequelae from cerebral edema. It can also be classified based on fluid status, so you can have hypervolemic hyponatremia as well as hypovolemic hyponatremia, and this just means that there's volume overload in hypovolemia, as we would expect, and volume depletion in hypovolemic hyponatremia. And it is actually quite important to make the distinction because the presentation can be slightly different with weight gain associated with the hypervolemic cases, as I will get into later. And it is usually the hypervolemic cases that are associated with symptomatic EAH. So the incidence of asymptomatic EAH has a wide range reported, from 0 to 13% in standard marathons. Its highest reported incidence is with 161-kilometer ultramarathons, up to 51%. For the symptomatic ones, there was a review of over 2,000 athletes from 8 endurance sports, and the incidence of symptomatic EAH was 1%, and this is compared to 6% of asymptomatic ones. And the symptomatic EAH has been reported in a variety of activities, including endurance sports. So this includes marathons, ultramarathons, triathlons, hiking, even police training, military exercises, football. Since about the 1980s, which was really a time that we started hearing more cases of symptomatic hyponatremia, and since about that time, there's been about 14 related deaths, at least 14 related deaths reported. So the number one risk factor for hyponatremia in exercise is persistent, sustained fluid intake that is in excess of thirst, leading to weight gain or weight maintenance. And as I mentioned earlier, this is a type that is often associated with symptoms. Other risk factors include longer race time or slower training pace, longer duration races, event inexperience, lower BMI, readily available fluid stations along the race routes. There's also been some association with NSAID use in literature, although the results have been inconsistent, with some showing a positive association and others showing not. And the paper that I will present later on the Boston Marathon actually did not show that there was increased risk with NSAID use. There's been a couple case reports of symptomatic hyponatremia in heterozygous carriers of the cystic fibrosis genotype, even from low-intensity activities, with the ones reported being Bikram yoga, long bowling, and the mechanism that they thought was that these people are salty sweaters. They excrete more salt through their sweat because of a mutation in the CFTR protein essentially. But more research is obviously still needed in this area. So before delving into the pathophysiology of hyponatremia, I want to spend a couple minutes just talking about normal physiology on water and sodium regulation. So our body relies on serum osmolality to decide how much water to take in or to excrete. So the normal serum osmolality is around 285 milliosmol per kilogram. And as you can see on the right-hand side, you have increased osmolality from things such as water deprivation, solute ingestion, or diarrhea, which is sensed by the hypothalamic osmoreceptors, leading to ADH release, which then leads to water retention, as well as your thirst mechanism is turned on, leading to water ingestion, all acting to normalize serum osmolality. On the left-hand side, you have decreased serum osmolality from excessive fluid ingestion, which is actually the case for exercise-associated hyponatremia. So in this case, again, the osmoreceptors sense that there is decreased osmolality, leading to a suppression of ADH release, which then allows water to be excreted, and your thirst is also suppressed as well. So I can talk about water regulation without a talk on sodium regulation. So believe it or not, the regulation of sodium in our body is actually not as important in the etiology of exercise-associated hyponatremia. So the main marker that our body uses for sodium regulation is plasma volume. On the right-hand side, we have volume contraction, meaning that you have decreased fluid volume, with it decreased blood pressure, and with it stimulation of the renin-angiotensin-aldosterone system, which leads to sodium reabsorption from the kidneys, thereby preserving blood volume. On the other side, you have the opposite being true, so you have increased blood pressure, which then turns off the RAS system, leading to decreased sodium reabsorption, and with it, diuresis. The pathophysiology of euvolemic and hypervolemic VH is such that there is total body water expansion relative to total body sodium. And this is primarily from an overconsumption of hypotonic fluid in the form of water, or even most commercially available sports drinks. And this is in excess of what your body is able to lose. There's also a component in non-physiologic ADH secretion as well. As you see from the diagram shown earlier, when you have volume expansion and low serum osmolality, your ADH is expected to be turned off, but there are many known stimuli for ADH secretion with exercise, such as nausea, vomiting, interleukin-6, elevated temperature that may be at play, causing this SIADH picture essentially. So with this type, as I mentioned, you typically have weight gain, and this is responsible for clinically symptomatic EAH and is associated with most cases, almost all cases, of morbidity and mortality. In the hypovolemic form, there is a loss of both total body sodium as well as total body water. Just relatively, you're retaining more water relative to sodium. And this is seen in longer and hotter races such as ultramarathons, hot Ironman, distance triathlons. And in this type of sport, you typically have high sweat rates causing both sodium and volume depletion. And because sweat is hypoosmotic, meaning that there's actually more water loss relative to sodium, initially you have a hypernatremic picture. But with increasing osmolality, ADH responds by increasing free water reabsorption. This is actually thought to be a minor mechanism in the etiology of hyponatremia in this case, with most kind of people in the field thinking that there is likely a component of overdrinking in this case as well. And typically you see weight loss with a longer duration activities. Here's just a pictorial representation of the two different forms. In hypovolemic hyponatremia, you have weight loss, and sodium depletion is thought to be one of the mechanisms, whereas in hypervolemic hyponatremia, you have weight gain associated with excessive fluid intake and the increased ADP or ADH. So the clinical presentation for mild EAH is fairly non-specific, but the key is that there is no neurologic compromise. So it can range from lightheadedness, dizziness, nausea, puffiness to weight gain from baseline. In the severe symptomatic form, which is often dubbed as EAH encephalopathy, you essentially have cerebral edema plus or minus non-cardiogenic pulmonary edema. And with it, you have vomiting, headache, altered mental status, seizure, coma, respiratory distress, may even see decorticate posturing or mydriasis, which indicate impending brain herniation. And this can be life-threatening. The diagnosis of exercise-associated hyponatremia is made based on clinical signs and symptoms consistent with it, as well as a documented sodium concentration below 135 millimole per liter. The severity refers to the severity of clinical symptoms irrespective of the actual degree of hyponatremia, as you can actually have symptomatic cases from relatively mildly decreased sodium concentration as opposed to some asymptomatic cases that actually have a higher degree of the hyponatremia itself. And the third international consensus guideline from 2015 on this topic actually recommends large endurance events to have the capacity to measure sodium concentration on site to facilitate diagnosis and management. The differential is quite broad, as you might expect for an athlete presenting with nausea, dizziness, collapse perhaps. So it can be exercise-associated postural hypotension, which would get better if you put them intradelibert. So that can be one thing that you can use to steer you in that direction. Can be exertional heat illness, altitude sickness, hypernatremia, hypoglycemia, as well as acute coronary syndrome, as you have an exertional activity, right?
What are some of the other things, if you go back a slide, what are some of the other things that will cause those kind of vague symptoms? So lightheadedness, dizziness, nausea, puffiness. When you're considering emergencies in sports medicine.
Cardiac stuff?
Yeah, non-acute coronary syndromes, right? So you can think of some? Sure. Why would you get a Brugada syndrome? So what does Brugada syndrome lead to? Yeah, tachyarrhythmia. So if you're getting any kind of cardiac rhythm that essentially is going so quick that you're not confusing the brain, you're also going to get symptoms like this. So you go back to the list that was for. So that's another thing to consider. So, you're not, this list is nice and everything, but when it presents to you, it's kind of those vague symptoms. When you go back 2 slides, that's what happens. That's what you see on the pitch. That's what you see at an endurance event. So the question is if that's going to present like that, you have to have all those things in mind. Your basic approach in terms of your first response approach is the same. It's going to help you guide through what you're going to end up doing and the support, but it's just important to keep those in mind because even those are vague symptoms are very important to recognize it's something that could be underlying that's very serious. Sorry.
That's okay. to continue along the same line of thought, it is important to consider differential diagnosis in something like the collapsed athlete. So they actually did a study collecting experience from over 1,300 collapsed runners at the Boston Marathons, and they found that dysenteria, so some sort of either hyper or hyponatremia was present in over 30%, with hypernatremia more commonly implicated as opposed to hyponatremia. So a very important point, takeaway point from this is that it is important to have on-site testing to differentiate between the two, to guide your management, and in particular also because the treatment that you give for hypernatremia, which is essentially acetonic or hypotonic fluid, can worsen hyponatremia and lead to some of the feared consequences of cerebral edema. The treatment of acute EAH, when you're able to confirm by a blood test, that is certainly ideal. So it is stratified into symptom severity. When you have mild symptoms, as at the top of the chart there, your options are to fluid restrict the patient until onset of spontaneous urination. Your other option is also to give them a small dose of oral hypertonic fluid. This can be 100 ml of 3% hypertonic saline, or you can give them chicken broth, which is essentially 9% saline, and see how they respond. And for the more severe cases, as you're moving down the chart, you want to have IV access to be able to give them IV hypertonic saline. And the regimen that they have recommended in the most recent guideline is an IV bolus of 100 ml of 3% hypertonic saline, which can be repeated at 10-minute intervals until clinical improvement. With some of the more severe presentations down at the bottom, they recommend that physicians use their own clinical discretion to either give it more frequently or actually just to use a larger bolus of the initial hypertonic saline. So what if you cannot measure blood sodium concentration on site? So this most recent guideline suggests to initiate empiric treatment based on clinical evaluation for the severe cases of EAH. So basically EAH with neurologic symptoms, encephalopathy. For the milder cases, you would still need to confirm hyponatremia based on serum or blood testing before initiating treatment. So that is the major differentiation there. Just like with everything in medicine, the key is prevention. So the current recommendation is to drink to thirst, which will help to minimize hyponatremia as well as to prevent excessive dehydration. Some of the other strategies that have been looked into include sodium supplementation. So all sport drinks are hypotonic, meaning that they are less concentrated than normal saline. So giving athletes sport drinks is likely not harmful, but if they drink that in excess of thirst, it could still precipitate EAH. What about sodium tablets or high salt diet? This is also controversial with some inconsistent results reported in literature, basically with more research needed. There is a recommendation to calculate sweat rates and for an athlete to basically individualize their need for replacement based on their sweat rates and their before and after weight change. There is also the thinking that more education programs are needed for educating the athletic community on what EAH is and the fact that mild dehydration volume depletion up to 3% of body mass is actually not harmful, and that drinking in excess of your thirst actually does not help with some of the thinking of fatigue or muscle cramping, or help to prevent or help to increase or better their performance. And there's also the thinking of reducing the availability of fluid station along race routes. There have been a couple reports of people doing this and having positive outcomes, but more research is needed to quantify exactly how many stations we need, how far apart to place them, etc., etc. So the first article that I will review is Hyponatremia amongst runners in the Boston Marathon, published in the New England Journal of Medicine in 2005 by Almond et al. The population in this study consists of runners participating in the 2002 Boston Marathon. They were 18 years or older. They were recruited 1 to 2 days before the race start, and they were approached at random. Basically, the investigators of this study wanted to evaluate the incidence of hyponatremia in this cohort by collecting their blood sample post-race, and also to identify variables that are linked to the development of hyponatremia by having the athletes do a survey on their baseline demographics, their training habits, as well as by having them do a questionnaire post-race on their fluid consumption as well as urine output. Weight was measured both pre and post-race. So here's a chart of all the participants essentially. There were 766 runners enrolled, with about 2/3 of them reporting to the finish line research station. And of those subjects, we have a final number of 488 subjects that were actually available for analysis at the end. So here's a table of the baseline characteristics of the subjects studied in the 2002 Boston Marathon. The ones highlighted show that there is a significant difference for those items in the runners that reported a finish line versus the ones that did not. So for the male runners, as you can see, the ones that did not report a finish line were the ones that had a higher BMI and were also slower. For the female runners, the ones that did not report a finish line had one fewer previous marathon experience. They were also more prone to water loading. So they showed that the mean serum sodium was 140 with a range reported there. About 13% of people developed hyponatremia, and of the total number, about 0.6% developed what they call critical hyponatremia, which is less than 120 millimole per liter. They have this table showing the different variables that they measured and whether it was a positive predictor for the development of hyponatremia. So under the univariate analysis, you see female sex highlighted and being a significant predictor for BAH. But after the authors accounted for BMI, race time, as well as weight change, female sex alone was not shown to be a significant predictor. Training pace and race duration were also associated with the development of hyponatremia. However, training pace was found to be collinear with race duration. Therefore, it was excluded from the multivariate analysis. So as you can see on the multivariate side, you have increased risk with increased duration of over 3.5 hours to 4 hours, as well as at the lower end of body mass index of less than 20. This is just a continuation of the same table. They showed that volume consumption was a positive associator with hyponatremia, but this was found to be collinear with weight gain, so it was excluded from the multivariate analysis. And as you can see, weight gain is a significant risk factor in this case. And here's just a table showing that the risk of hyponatremia increases with increasing weight gain, with weight gain to the right of the table and weight loss to the left side of the table. So some limitation of the study, the follow-up rate was 2/3, which is not optimal. The authors also speculated that the true incidence may also be higher than what was found, as those who did not follow up were generally runners with fewer experience, more likely to water load, who were also having higher BMI and was slower. The self-reporting fluid intake can be less accurate, although this did correlate with objectively measured weight change. In this study, they did not show that there was any positive association with NSAID use, but they also didn't quantify the amount that these people were using. So I think it might be helpful to stratify based on the amount and to see if there's any positive correlation with people who are using more NSAID. The second article that I'm going to review is the efficacy of oral versus intravenous hypertonic saline in runners with hyponatremia, and this was published in the Journal of Science and Medicine and Sport in 2014 by Owen et al. Population in this case consists of participants in the 2010 161-kilometer Western States endurance run. There were volunteers that were recruited 2 days prior to race start, and there were no specific inclusion or exclusion criteria. So just as in the previous study, they wanted to measure the athlete's weight pre and post. They also took sample after the race to measure their sodium concentration to confirm that they have hyponatremia. And if this was the case, and the athlete did not have any neurological symptoms and agreed to participate in the intervention trial, then urine was collected. They were asked to rate their sodium palatability as well as thirst on this 10-point scale. Each subject was then alternatingly assigned to either oral or IV 100 ml dose of 3% hypertonic saline. And at 60 minutes post-intervention, again, urine and blood samples were taken, and the subjects were asked to re-rate their sodium palatability and thirst. Here's just a flow chart showing all the participants in this study. There were over 300 people enrolled in the race in the study pre-race. So of those who enrolled, there was 2/3 of those that actually finished. So 199, that number. And of the people that finished, they had 166 blood samples drawn. Of these people, 48 were found to be hyponatremic. And of the hyponatremic runners, they had 32 that were then divided into the intravenous group or the oral group, with the final data point of 11 in the IV group and 15 in the oral group. Sorry, I wanted to point out, but didn't have the cursor. So the incidence of VAH in this cohort was 29%, which was actually fairly close to what the author predicted of about 30%. With either IV or oral treatment, the blood sodium concentration increased by about 2 millimole with no significant group or group by time differences. They also detected a mean decrease of body weight of about 2.4% post-race, again with no significant group or group by time differences. They found with the IV arm that there was more plasma volume expansion of 8.6% as opposed to 1.4% in the oral arm. So this is the first table in the paper that essentially showed that there was a time difference in blood sodium concentration pre and post-race. I also highlighted the level of ADP that was measured, and basically showing that there is no difference in between the pre and post measurements for both the IV and the oral group. As I mentioned earlier, they actually saw plasma volume expansion with the IV group. So with that, you might expect ADP to drop for the IV group post-intervention. But as you can see, this was not the case. And the authors speculate that there might be other non-osmotic stimuli to ADH release in this case, like the interleukin-6, nausea, vomiting, as I was mentioning earlier. This is the second table that they had in the study showing some of the urine measurements. I thought it was interesting that the oral group demonstrated more sodium excretion in the urine. So, which basically means that the IV group held on to more sodium in the blood. This actually makes sense considering that there was more plasma expansion in the IV group. So basically a bigger tank to fill, and it makes sense that the eventual change in sodium concentration was not different between either group at about 2 millimole per liter increase. I thought a major limitation of this study was that there was no control group. With that, I wonder how some people would do if you just allow their sodium to perhaps normalize on its own for an hour after the competition, and perhaps allow them to ingest anything elevated, be it a salty snack, to see if their sodium might normalize with that. Another limitation with this study was that there was no exclusion criteria. So given the small number of participants in this study, being 11 and 15, anyone with nephropathy or diuretic use could potentially throw off some of our findings here. I also questioned the significance of treating asymptomatic VIH in this case, and whether that can be extrapolated to the treatment of symptomatic VIH, which is what we are concerned about clinically. I also questioned the extrapolation of the results to the hypervolemic form of VIH, which is associated with more symptoms, as the treatment in this case was more for the hypovolemic kind. The data presentation, I thought, could definitely be improved, as some of the parameters that they had listed in the results section, the discussion of the results, including weight change and plasma volume expansion, were actually missing from the two tables that they presented. So here are some of the discussion points I have for the group. I wonder if it is the standard of practice currently to have sodium testing on site at some of these large endurance events. And also with asymptomatic VIH, a research question for the future could be what portion of them actually goes on to develop symptoms, to see if there's actually merit in diagnosing this and treating people with it. And another question I had was about how to facilitate education programs on raising awareness amongst the athletic community on this particular condition as well, and on the mandate to drink to thirst. And perhaps looking into the future of medicine with the advent of gene testing, individualized therapy, that perhaps we can test people for the heterozygous cystic fibrosis gene, thereby exposing those who are more at risk, and perhaps individualize recommendations for this particular group of people. And that is the end.